Good morning. We are with Kerry Assil, one of the top refractive ophthalmologists in the United States. We are going to share some concept about his experience in refractive surgery in the state. Kerry, what do you think is the most important thing you are doing now in refractive surgery? What do you think is something who you are enthusiastic? You think this is something new that really is going to impact in my practice?
You know, in the United States, many of the things that we get excited about are the clinical trials that we participate in, and those don't become routinely clinically available for another 3 to 5 years after that. So our enthusiasm is always tempered enthusiasm. Perfect example is the FlexiView micro lens with presbya. I started working with this technology 15 years ago with Vlad Feingold, the inventor, and it will be another 5 years before it's available clinically in our country, so it will be about a 20-year cycle. Currently available technologies, of course, we're very continue to be excited about the multifocal and the premium intraocular lenses in cataract patients, especially the technologies are now that are in the pipeline that will become available in the next 6 months or so with the lower ad thickness multifocal, for example. I think that space will continue to become more interesting in the years to come. LASIK continues to have slow but steady refinements. I think that the eye design technology that will enable us to do better wavefront treatments will be exciting. So we see advances across the board. Dry eye treatments are also becoming more interesting. The technologies using photofacial therapy or delight, putting light into the skin to reverse the abnormal blood vessels, allowing the meibomian glands to produce better oil. All of these things, I think, will become more and more interesting to us as we refine the technologies.
It's very interesting. We know all the restriction of the FDA. If the FDA allow you to use now anything that exists in the world, what is the first thing that you pick up now to introduce in the USA to use it? It's a tough question for you.
It is a tough question only because I'm certain that there's a lot of wonderful technologies out there that I'm not even aware of. Usually the best technologies are the ones that are hiding in somebody's garage still. Of the ones that I'm readily aware of and very familiar with, I would probably like the extended depth of focus lens that AMO has, and also the low ad lens, because in the FDA studies we found that that lens created tremendously less halo and glare than did the higher ad lenses, and gave the patients an increased depth of focus as well. So those might be the very first ones that I would grab onto.
Okay, this is a very nice point. We are talking about multifocality, and we are familiar with refractive and diffractive lens. Now we are going to start to be familiar with the new concept that is extended depth of field of new lenses. What do you think is going to be the biggest limitation of this technique? Because it's promises us a lot of things: less halos, less glare, easy adaptation because it's not a diffractive system. What do you think is going to be the biggest limitation? Or highest limitation?
Not enough near. Okay. The lens will be used probably as a mini monovision. They will make one eye at distance, the other eye give some ad, hoping to bring in that near, but still not enough near for all patients. People that are happy to work just on the computer and distance will probably be happy with them. Those who want to be able to thread a needle or have more up-close visual demands working on their small cell phones will be less excited about them.
Okay, and if you have an extended depth of field lens, and you can use it in a phakic lens, what is your opinion?
So an extended depth of focus as a phakic IOL would of course be very exciting because this would now take your high myopes and patients with large refractive errors that you're treating and enable you to leave that lens in their eye for a very, very long time, assuming that they're not going to develop cataracts along the way. So I think this would be interesting because in the extreme myopes, we're very reluctant to perform clear lens extraction for the concerns that have to do with the retina. So it would be very nice to give them this.
Okay, Kerry, it was a very big pleasure. I think you enjoyed this nice interview. Thank you very much.
Thank you. It's always good to see you. It's good to finally see you in your own home country. It's a pleasure for me to be here.